Thank you very much. Thank you, Angela, and thank you for those in the room. It's a lovely sunny Friday afternoon, so I do appreciate you coming to this room, and thanks to those online who have joined us as well. I'm going to be talking about non-pharmacological interventions and creative mental health. This is a picture of Damien Hirst from 2014, and he's made medication for his art, and it followed a famous exhibition at the Tate Modern where he did an installation of a pharmacy. So why have I brought this word into our room and into our virtual room, non-pharmacological? Because I could have used other terms. The reason I've done that is because it's context setting. So what I want to show to you is that in health research, it's very much dominated by pharmacological narratives about how research is designed and delivered, and how that's going to influence the context of the work that I'm showing you. So there he is, Damien. I hope you all look better than him at the end of the talk anyway. So what are we going to look at this afternoon? We're going to look at definitions. So we're going to, first part, we're going to think about some definitions. So we will look at non-pharmacological interventions, psychosocial interventions, complex interventions, and the overlapping nature of all of those definitions. There are strands that you'll see running through them. And then I'm going to show you a couple of films that also talk about creative health and arts therapy, so we've got an understanding of that. Then I'm going to move on to give you some examples of work that I've been undertaking, different evaluations and studies, and talking about, again, those kind of contextual influences on some of those studies as well. And then finally, we'll finish off with some challenges around this work. And just to be kind of explicit with you, right from the outset, my main point, if you like, my main argument is going to be who is the audience, because whoever the audience is will determine what and how success is measured. So I come at this from two perspectives. So one is a personal one, and one is a kind of more community-based one. So as a therapist working in the NHS, I started to collect outcome measures from people that I saw. And that was a decision because I wanted to kind of make sure that people were actually getting better, and I didn't want to do any harm to those patients. So it was a way of monitoring that. And that wasn't the only way of monitoring that, but it was one way of getting feedback from people. So there was a kind of ethical stance from the beginning. But what happens now is I'm often invited to charitable organisations, creative health organisations and therapy organisations, and they say, Simon, what outcomes should we be using? We've been asked to collect these outcome measures. What should we do? And I say, well, who is your audience? Who's asking for these? Because often it's funders of those small charities and projects, or it's commissioners that are wanting some kind of evidence and a metric attached to it that can show that there's a demonstrable improvement due to the services they're making. So my question really is, are we asking the right questions? And you may sit there as I talk, and if you decide that I'm not asking the right questions, I'd love to speak to you afterwards, because that would be really interesting. So different perspectives on this are really helpful. So that's the thread that's going to run through this today. So why non-pharmacological and creative therapies? Well, what I would say is this isn't against medication. So many of the people I work with in mental health problems in services benefit greatly from medication. So that's not what this is about. This is about the kind of paradigm and context of evidence-based generation that comes from, I think, pharmacological studies and backgrounds, and their influence on healthcare and the health effectiveness and health economic context that we're in as well. Okay, so let's get into some definitions, and hopefully you can kind of follow some of the threads here. So let's go for non-pharmacological interventions first. So this is surgery, rehabilitation, education, psychotherapy. I highlight because that's what we're going to be thinking about. Devices represent a wide range of interventions. However, pharmacological interventions raise specific methodological issues related to complexity, the intervention, the influence of care providers, and expertise of the Centre of Difficulties of Blinding. Okay, so what's blinding in this context? Blinding is whether the people administering the research are aware of the condition of the participants. So one group would get the intervention or treatment and one would not, and the researchers, due to reducing bias, are supposed not to know what that condition is. Now, what I just want to make my first point here is that there are methodological issues, but where do they arise from? The methodological issue is because in a non-pharmacological study, you can't repeat the standard of a pharmacological study. So within the pharmacological study, you can issue medication and it can be exactly replicated and nobody knows what they're getting. So they're saying that now this is a methodological issue. So if you see my point, it's the standard is a pharmacological standard, which we're now applying to a non-pharmacological intervention. Okay, so then we've got complex interventions. This include a number of interacting components with the need for specific expertise, skills or techniques being applied by those delivering or receiving the intervention. So in some cases, it may be that if you're receiving the intervention, you also need to have some expertise or develop expertise during the intervention. There are obviously contextual factors, which might also require flexibility and tailoring. And then there's intervention components, which could be group dependent, individually dependent, or the setting or organization. So there's layers and layers and layers of complexity. And this is the work of Skivington 2021, and it's a revision of a previous framework for complex interventions. And one of the benefits of this framework is it very much thinks about context and the influence of context on intervention. So let's move on. We've got one more to do. So psychosocial interventions that emphasize psychological, behavioral, social factors rather than biological factors. And they include interpersonal, informational activities, behavioral, cognitive, emotional, social, environmental. So and so, you know, you can pick up threads through all of these things, but psychosocial complex interventions. And we did do some work, a systematic review. This was my colleague Jane Vaughan led on this one, of community psychosocial group interventions for people with learning disabilities or intellectual disabilities and mental health conditions. So we were interested in what community provision there was for people. And because we're interested in this kind of thing, we also looked in the descriptions of those studies to see what creative methods were included. So these weren't arts intervention approaches per se, these were broadly psychosocial interventions, but we noticed that there were creative elements to these interventions, many of them which seem to optimize them as well in this client group. Okay, so I want to, this isn't a definition, but I just wanted to draw your attention to this. So this might all sound wonderful, non-pharmacological, complex psychosocial interventions, and they're often considered low risk interventions. But I want to draw your attention to the work of Chris Bonnell on dark logic, and he does some work theorizing on harmful consequences of psychosocial behavioral social interventions. And so whenever we're starting to think about designing interventions or implementing things, I think it's really important to think about unintended consequences that might occur from interventions. And so that's something we also consider strongly. So I recommend that work to you as well. Okay, let's have a think then about these definitions of creative health. So this is from the National Centre for Creative Health. Creative health approaches activities which have benefits for our health and well-being. Activities can include visual and performing arts, crafts, film, literature, cooking and creative activities in nature, gardening, involve creative and innovative ways to approach health and care services, co-production, education, workforce development. It's fantastic, isn't it? I mean, that's really, what a great list. I think that's tremendous stuff. Creative health can be applied in both homes and communities, and cultural institutions as well. So this group came from an all-party parliamentary group that then has developed into the National Centre for Creative Health. But so I'm going to show you a little video from the centre now, which is a kind of emphasis around commissioning. So how does creative health get into the health system and get commissioned? So hopefully this will come through to everybody. Yep.
Health is not just about the absence of illness or disease. Good health takes into account the people's ability to live more fulfilling lives, but also to interact with the space and engage with the space that's around them, and also to explore their creativity. Creative health, if thought about at the outset, can play a big part, not only in terms of delivery, but it can also help shape your commissioning. There is international evidence that tells us that the effectiveness of engaging in creative health programs is significant. I would urge those colleagues who are thinking about new services and new pathways to consider embedding creative health approaches, because the return on the investment is significant, and let alone the impact that this can have on individuals, on communities, and on the population. A lot of the assets that we rely on in creative health are either not funded or they're really struggling on shoestring budgets. And I think commissioners would get a lot more value for the population health by investing in some of these creative health assets. My vision for the future of creative health is that it becomes front and central, and we need to embed it so that it's not an optional extra, it's not an afterthought, but it is part and parcel of how we support our populations to achieve better health.
Okay, so that was, really encouraging, wasn't it? Creative health and commissioning. You heard a few key words there, so return on investment, and you also heard that many of these resources are struggling on a shoestring. And I can tell you just from my experience of interacting with community groups and arts groups and creative health groups, that actually the current situation is very difficult, very challenging actually, and so the funding kind of scenery is pretty difficult out there. But there are some efforts, I think, to raise the awareness of creative health, particularly around public health as well. So let's move on then to art therapy. This is from the British Association of Art Therapists, but I could also have given you information from the British Association of Music Therapists, Drama Therapists, or Dance Movement Therapists. Arts therapists are health and care professions registered clinicians or therapists, and they train for 2 years at a master's level, really as psychotherapists, but using creative approaches as well. So this is the information to people that might access that. So they often work in a range of settings, including health settings as well. So this is the information, what you can expect. You're going to work with a therapist, you could be in a group, and art therapists might sit quietly, or you can work with them, you can talk to them, think and make sense of thoughts and feelings, but it's sort of like a confidential therapeutic space for people. So there's also a video from the British Association of Art Therapists, so I'll play that as well.
Art therapy is a form of counselling and psychotherapy. It provides a safe space for someone to communicate and express themselves creatively through art making and reflection.
So you need to be good at art, right?
Art psychotherapy isn't like an art class. You don't need any art skills or previous experience. The art therapist is there to support you as you find your own ways to express yourself. Maybe through art making, modelling, collage, using your imagination, even scribbling.
So it's more for children then?
Now, art therapy is for everyone, for all ages and all stages of life. It can help people in many ways, like those struggling with trauma, big life shifts, physical health conditions, or disabilities. Those who are non-verbal or don't have English as their first language, substance use or negotiating mental health difficulties. You could even explore parts of your identity and how they influence your experience of the world.
Okay, so how does it actually help me?
Our feelings, thoughts, and experiences can sometimes be the hardest things to express. They can become confused, overpowering, painful, or even seem really detached from us. An art therapist aims to create a space for you to explore all of you, even the most challenging parts, in a way that feels safe. Using art materials offers you a different language to communicate and learn more about yourself when other ways don't quite fit.
Where could I find an art therapist?
Art therapists, who can also be known as art psychotherapists, work in many settings. They see people individually or in groups, and sessions can be in person or even online. You can contact your GP or social prescriber, teacher, local charity, or search Find a Therapist on the BAT website.
Thank you.
You're really welcome.
Okay, so that's our definitions concluded then. So we've got a context of psychosocial, non-pharmacological complex interventions, and you've set the scene for arts in health and creative health and art therapy. So we've made it to part 2. So that's great. So we can now look at some examples of things, and we're going to look at our first example is music participation for children and young people in hospital. And this was work that was funded by Youth Music, the Foundation for Youth Music. And we had partners there with what was the Sage Gateshead at the time, but now the Glass House and Newcastle Bridges School, the Great North Children's Hospital, and Cumbria, Northumberland, Tyne and Wear, NHS Foundation Trust and Northumbria University doing some of the evaluation as well. So I'm going to talk about the evaluation of this, and the evaluation started with Youth Music because in order to have a competitive application, you had to write an evaluation plan that would get reviewed in order to get the funding. So we did that. Okay, so project 1 was Youth Music with 20 months, 68 sessions, 70 young people, 9 to 19 years in an NHS inpatient mental health setting. And then project 2 was Singing for Health, 16 months, 125 sessions delivered to 119 young people, 9 to 17 years in mental health, and a secure mental health hospital for children and young people, and a paediatric general hospital. The team was led by music therapists, but it wasn't a music therapy project. It was facilitated by community musicians and music practitioners. And there's kind of loads going on in terms of different types of music, recording, sharing the music and performing the music as well. So as part of our evaluation plan, we collected some data. We got 177 participants, and to analyze that data, we took the people that we got more than one measure from. So there's sort of temporal difference between their kind of time in the program and in those sessions, but there were 80 that just came once actually. So we didn't include them in our analysis, but I like to think that that was something that was positive to children and young people who were in hospital, whether a physical hospital or mental health hospital, maybe for a short time, but that music participation sessions were happening there. So we looked at pre and post measures using the Youth Music Wellbeing Scale and the Creative Arts Therapy Session Rating Scale, which is an observational scale as well. And we designed that because some of the people we work with, it's actually quite tricky to facilitate written feedback and forms. So we devised this observation scale, and then we've done some work on inter-rater reliability of observers to check that there's agreement between them. So there's a little bit of validity around that as well. So what did we find from these things? Well, there was a significant increase in the wellbeing ladder scale, so that was positive. And then the social skills and the motivation and participation was also. So there were some good outcomes. I suppose what I want to illustrate to you is that these are very narrow, limited metrics, but they tell a story. What we also did was we embedded some realist evaluation within this work. So realist evaluation could be summarized as what works for whom, under what circumstances and how. And this was part of Andrew Fletcher's PhD, who did spend some time at Durham and published this while he was here. He's now back at Northumbria. And we identified these 4 Ps, participatory arts recovery model, were for peers, product, personhood, and positive interaction. And we interviewed children who'd accessed these music sessions, and also adults who were accessing a community arts studio, making music, and young people with learning disabilities in a vocational program also doing music. And there was a range of methods used: interviews, focus groups, and participatory observation. So Andrew wrote up this really nice model, and you can see it's kind of interactive. So we have, you know, personhood, which was about identity and use of music to help people form and talk about identity and share identity in terms of common interests around music. Also, the interaction with peers was really important. That positive interaction was highly valued and praised from peers. And also the product, making a recording, producing something, doing a performance, all of those things interacted to be really positive experiences for people. So in the paper, actually, it's elaborated on quite considerably, and there's some nice examples there. We then tracked this onto a recovery model. So this is the CHIME model around connectedness, hope, identity, meaning, and empowerment. And so I just you know, put those up as a kind of model around how we could maybe summarize some of those interactions and those important things that seem to occur within these creative arts programs. Andrew then went on to write a nice methods paper, The Bagatelle of Human Flourishing, which is a really nice title, and using realist evaluation to disentangle multiple wellbeing benefits. So I've got a link there as well for that. Okay, let me move on to another example. This is about co-development of complex interventions in art therapy with children with juvenile idiopathic arthritis, and this was funded by Newcastle Hospital's charity. We also worked with the Teapot Trust, who are an art therapy charity for children with long-term health conditions. Okay, so what we know is that anxiety and depression levels in children with juvenile idiopathic arthritis are higher than their peers. And we also know that the presence of chronic conditions can result in more severe mental health problems in children, but there are barriers to some mental health referrals and gaps in service provision. So we looked at developing group art psychotherapy intervention for communicating the needs of children, but we just call it GAIN because that's a little bit more straightforward. Now, there was a survey done, and what we know is that 82% of the participants in the survey reported that children's juvenile idiopathic arthritis diagnosis impacted on their mental health. But we also know that 54% of them were never offered mental health support during appointments. So we were wanting to see how we could kind of integrate this and support children who are in those health systems. Okay, so this was the paper that we wrote about it, developing this online group for children and young people with long-term health conditions. And this is an adaptation of the complex intervention framework, and we followed these phases through. So planning the development process, formation of a stakeholder group, decision-making team, identification of relevant literature and theories, and then intervention refinement. A couple of things to point out here were, you know, integrating patient and public involvement throughout this. And also what I quite like is in these guidance, they say use creative activities within team meetings with stakeholders. So creative processes are there in a co-production as sort of part of the co-production as well. Okay, and then this was our sort of map of patient and public consultation in our steering group, in the drafting of our manual, in the modification responsive to the literature and theory, and then further responses from stakeholders, then further consultation around developing age-appropriate materials, and then developing a manual-based intervention. So then we ended up with this this kind of 6-session online intervention for children, and we've woven through these kind of themes. So there's a kind of theme for the meeting, but there's also some free art making time. They get sent art materials out through the post before this happens. And then there's some preparatory kind of work that they could do with home sessions. And I suppose the thread running through it, the theory, is that we're trying to support these children and young people who are in contact with health services to develop some self-advocacy and confidence about how they talk to their healthcare professionals as well, and integrating that with family who are often doing a lot of caring responsibility and supporting those children and young people. And what we found was the younger people in our kind of work, they did some of this home session stuff with their parents, but older children, teenagers, just kind of prepared themselves. So there were kind of different ways of using that. All right, we're not going to go into detail here, but what I want to also illustrate to you is this model is around developing logic models. And so this is an example of one in complex interventions. And so you can see we actually consult about 44 children and young people. And we have a theoretical basis for this. And then you'll see things popping up here, like peer support is really important. We've got art materials and guided discussions and art-based activities. And then we've had a think about the mechanisms and the outcomes. Okay, so this is all language that I'm giving you now because it will be picked up later within the model of these frameworks and how they're devised. Okay. And also you've got dark logic there as well. So we're trying to think about what are the unintended consequences. So some of them might be that some young people struggle to share in groups, digital poverty for an online intervention, and constraints of time. But there may be other unintended consequences that we also need to think about. Okay, so let me go through some questions with you. Do you think this approach was acceptable to children? Yeah, it's pretty acceptable. They were involved in designing it, and we piloted it, and yeah, and they stay in the groups and they complete the groups and they do the worksheets, and yeah, it's pretty acceptable. Did the children think the standardized outcome measures were acceptable? Yeah, some were, some weren't, and that was really good to test out. So we spoke to the children and young people, we let them read them, and the measure that I thought would be, as a researcher, the best measure, because it has loads and loads of population data that we could compare the children to. It's been used in lots of studies, and you know, if as a researcher picking this, I would think this is going to give me some great results. Did they like that one? No. The reason they didn't like it is because it's very behavioral questions. It wasn't really appropriate to them. But as a researcher, I had everything there in terms of the comparative data and the usage and the validation, which was really good. So we looked at other measures. Do you think if we asked them about a design for a future study of this, they would like a randomized control trial where they got to wait on a waiting list for this intervention, or they could get the intervention and it was completely decided by random? What do you think they thought about that one? Yeah, no, they didn't like that because what's treatment as usual? We know what treatment as usual is. Nobody talks to them about their mental health support in routine clinics, so they didn't like that. And also, if we designed a study based upon our outcome measures and we calculated how many young people we would need to include to get a significant result, we probably didn't have enough young people to do that as well. So what did health research methodologies reviewing this proposal that we put forward, where we said we won't randomize them, we can take their information at the beginning and we can compare that at the end. So we're just comparing each person against themselves. They don't get compared against another group, and you know, so there's sort of little disruption, no randomization. What do you think they thought of that? Panel of health research methodologist funders didn't like that. They said, no, you should go back to the waiting list control. That's the right design for this. Okay, but that's not what our public and patient involvement told us. Okay, so the NHS chief executive's question. I was called to a meeting. It was with the research director of the NHS Trust, and it was for a small animation project that had been running in an inpatient ward, a mental health inpatient ward for women. And the animation project was running, it was going really well. There was lots of nice engagement. But they said to the chief exec, how could this be funded? Could the NHS give us some more money for this project? What do you think the chief exec said? He said, well, we could, but what you would have to demonstrate is that your animation intervention on that ward reduces the number of incidents that are recorded. So in the NHS, there are incidents that are recorded which could be somebody is at a risk, or you know, there can be an intervention by nursing staff, or you know, a breach of something, and you know, so they're incidents. So if our animation project reduced risk and you know, violence, aggression, verbal aggression, those kind of things, then we could fund this. Okay, that's a pretty tricky thing to demonstrate, actually, and I know that because I've had a go at it. So this is a secure care hospital in Northumberland, and people come into the hospital because they've committed a criminal offence, and they've been in prison, or they've come through the courts, and in addition to their criminal offence, they've also got a mental health problem or a learning disability that requires some specialist support in hospital and some specialist treatment. So that's the population. And we have done this work, which was interpersonal art psychotherapy, and we're looking at the treatment and reduction of aggression. And what I would say is that as a contextual, institutional question to answer. So we know that in these settings, compared to other psychiatric settings, there are more aggressive incidents in these populations. So that's a kind of question that is an institutional one that would be interesting to look at. So we've done this preliminary work, feasibility studies, to see whether we could just conduct a study like this, and then we've designed a full randomized control trial, and that's our protocol, and it's called the Secure Care Hospital Evaluation of Manualized Interpersonal Art Psychotherapy. Okay, so a population, people with learning disabilities or borderline intellectual functioning. Unfortunately, this is a group that's slightly overrepresented in the criminal justice system. People with neurodiversity in the criminal justice system, slightly overrepresented. We did all our fancy calculations, and we thought we'd get 200. That was what we needed to recruit 200 people to this study, and they get randomized to interpersonal art psychotherapy, or they get to a waiting list. How long's the waiting list? 9 months. 9 months. And what happened when I went to the ethics committee, I put this design to them, and the methodologist said to me, you've got a follow-up period, so that's why people have to be in the study for so long, because we're waiting for them to have the intervention, then we wait a bit longer to see how it lands after a while. And they said, could you extend your follow-up period? And I said, no, I don't think we can. I think we've stretched that as far as we can go. And the chair of the committee said, no, that's not our recommendation. But interesting that it was a methodological perspective that really would like to see longer follow-ups. So there's some challenges here. So we have done some process evaluation. We've interviewed people who are on the waiting list and were randomized, and we've interviewed people in the study. So we are collecting data about people's experiences of just being in a trial like this. So there's our observed aggression primary outcome. But what do you think the most important outcome is for participants and from our patient and public involvement consultations? It is reducing distress is what's really, so that's our secondary outcome, but you know, that's also, I guess, in some ways a more important one. So the other point I'll make is we're looking at effectiveness, obviously, and cost effectiveness. And this is really interesting because we know that cost benefit is a kind of primary indication of whether something will get commissioned. And within secure care, I had a chat with my health economist on the team, And essentially, it works like this. If you can do an intervention and then demonstrate a cost saving by people reducing their access to services or resources, health resources after the intervention, that shows you a really nice cost benefit. You've done something, now they're not using health services as much, can reduce it. But actually, what I was trying to explain was, if my intervention works, we don't know yet, but if it does, what I'd expect is people to do more, so their risks are reduced and they can access more health professionals and do more and actually access more resources. So it's actually going to cost you a little bit more, perhaps. So okay, we also did co-production with this group, the Research Abilities group in Newcastle, and they supported us through our kind of intervention, advising us and on all the materials related to the study and dissemination. Okay, now I won't go into detail about this. This is what the intervention components are, but in the context of complex interventions, you can see there are components and there's layering, there are behaviors that the therapists are supposed to do and ways that they work with the participants. But the kind of engine room of this is that there's a sort of shared understanding that's reached, and there's generation of artwork in the sessions, so people have time to make artwork, and some of it's theme based, and then they discuss it with the therapist, and it's designed to help people who've got communication difficulties being able to kind of communicate and have things that they can talk about which are personally related to them. Okay, so I'm just going to show you one more film. This is the last film, but this is our kind of participant information on video, and then we shall get on to challenges quickly after that.
This is Dan. He is 22 years old and is in a hospital with secure care after an assault he was involved in. Dan has a learning disability and struggles with reading and communicating. He sometimes ends up hurting other people when he feels that they don't understand him. In the past, people with a learning disability were not invited to take part in research. This means that it's not always clear what type of help and therapies work well. Schema: Secure Care Hospital Evaluation of Interpersonal Art Psychotherapy is a research study aiming to understand how art psychotherapy can help Dan and people in secure care who have learning disabilities and other people who have learning difficulties like reading, writing, and struggle with communication. Art psychotherapy is a psychological therapy where people work with a therapist and make artwork to help them to communicate about any difficulties they are having. Art psychotherapy is accessible. Many of the psychological therapies available to people with mental health difficulties are based on talking. This might not always be the easiest way for people with learning disabilities or learning difficulties to access a psychological therapy. Art psychotherapy can be helpful for people who find it hard to talk about what they are thinking about, feeling, or struggling with. Doing artwork or creative things as part of art psychotherapy can be a helpful way for people to communicate about themselves and share the things they are frustrated, angry, or distressed about in a safe way. In the schema study, we want to find out if art psychotherapy is helpful for people who are in secure care. We will be looking to see if interpersonal art psychotherapy is helpful when it is offered alongside all of the other care people get. To do this, we will recruit 200 people with half having interpersonal art psychotherapy and half going on a waiting list for it. This is called a randomized controlled trial, RCT. If people get the therapy straight away or go onto a waiting list for it, this is decided by chance, like rolling a die but everyone who takes part in the schema study will have art psychotherapy. We will also ask everyone who takes part in the study to complete questionnaires. People who have a learning disability and learning difficulties helped us design the study. They looked at the therapy manual and told us what they thought worked well and what could be made better in therapy sessions. A theatre company run by and for people who have a learning disability will help share the results of our research through performances. We will find out if interpersonal art psychotherapy can help people like Dan. We will see if doing creative activities can help Dan and others improve their mood, become less distressed and bothered by things so that they will feel safe and the people around them feel safe. We think that this research will give people with a learning disability and learning difficulty more choice about the psychological therapy they have in secure care. If you have any questions or ideas related to schema, contact us using this email address.
Okay, so that was our kind of patient information leaflet. Okay, we've made it to part 3. Okay, so well done everybody. We're just going to look at some challenges before we conclude then. So you know, I wonder if really we've been asking the wrong question, and really what we should be asking is, what is art? That's the kind of question I think we should have been asking. This is based on the work of Skov and Nadal, and in the art and health hypothesis, what is art? So they wrote a critique, a paper, and says we also found they did a review of studies, and most studies failed to define what art is and prove that art elicits physiological processes that directly affect the etiology of disorders. So their paper was on, can arts-based interventions improve health? A conceptual and methodological critique of art therapy. Now, I would like to point out that I think there's a kind of slight error, a category error on art therapy, because art therapy in this paper I don't think is described as a definition that we previously looked at and would understand, but certainly arts-based interventions, I think we could say that they do look at that. They conclude that there's no compelling evidence that art objects and activities can include physiological changes to the human nervous system that result in health improvements and well-being. So I've just put that picture up of the young person drumming in the drumming workshop from the commissioning video, and I wondered if there was something physiological going on during that session. But helpfully, Skov and Nadal have given us 18 recommendations for studies that we think could answer this question. So here we go. So I've kind of done a little bit of a traffic light response to this. So we've got green ones, orange, which might be a bit challenging, and then some red ones. And I'll just talk you through briefly these things. So I'm not going to talk through the green ones, because I think, you know, lots of these you would expect to see in studies like these kind of designs. But did the authors identify the mechanisms by which the arts-based intervention would be expected to be beneficial? Well, we've got logic models, and we've got some theoretical processes. We could think about that. I think we've got some idea about mechanisms. We might not be able to be completely assured of those, but you know, we can have a go at that. Did the design include a control group that was subject to no arts-based intervention? Possibly, yeah, that's okay. It's a little bit challenging, but you know, might be possible. Did the design include a control group that took part in an equivalent or non-artistic activity? So control groups, really difficult. What are we comparing against? It's actually quite hard, and if you compare against treatment as usual, it's really complex. You know, lots of things happen, and we don't really fully understand them. So were the researchers conducting the assessment blind to the participants' condition? Well, if somebody's doing a creative health intervention or not doing it, you kind of know, don't you? So it's a bit hard to do that, but within the study, the schema study, we put in place procedures where the researchers, at the point of our primary outcome measure assessment, we try to get them blinded so they don't know which arm of the study they're on, although we've got procedures in case somebody tells us, because that could happen, and we're working with people and they could give things away. So there's challenges, but we can deal with that. But where the patient's blind to their condition, either treatment or control group, I haven't worked out an answer to that one. I think that's really hard if you're looking at people attending stuff and getting an intervention. It's hard that they don't know what it is. I haven't quite worked that one out, but that would be the perfect experiment for arts and health. But then we've also got, did the authors determine the necessary sample size? Well, yeah, we can do that. And you saw my study was very ambitious. We worked out from the measures, the sample size, but we were going to need 200. And actually, it wasn't possible to recruit that many people. So it's really difficult, because these measures have high confidence intervals, and then you get a sample size, a power calculation. And in these bigger sample calculations, it's actually hard to get participants from smaller groups that have high needs. Did the study provide evidence of the mechanisms responsible for the effects? Well, we could do that, but if it's a physiological one, we haven't probably got to that yet. Okay, so here's my point then, really. So psychosocial intervention studies, we've got inherent weaknesses before we start. There's a random allocation. So one of the examples from my study was we had clinicians who were enrolling participants because our participants had learning disabilities and learning difficulties. So in order to make a judgment about their consent to participate in the study, we had clinicians in the room. And then what would happen is the person would get allocated to a waiting list. And the clinician would come back to me and say, "Oh, it's a real shame, Simon, because I thought they'd get on really well with this, and I thought they'd really engage." And so actually what we have is this tacit knowledge about compatibility and pre-alliance that therapists and clinicians, probably arts practitioners and others might get a view of, and we're kind of ruling that out. And actually what we do know is that therapeutic alliance probably leads to some of the strongest outcomes in therapies as well. So just an interesting observation. Blinding, we've already talked about. Okay, final few points then. So the sample size is really difficult. It's usually very high compared to the number of participants that are eligible. So we looked at this, and actually in art psychotherapy studies of insecure care, where we were doing ours, you can see it ranged from 7 to 159 with a mean of 47, which is pretty much exactly what my study recruited. So you can see that these are inherent difficulties. But if also we just look at broader non-arts-based psychosocial interventions like cognitive behavioral therapy and others in these settings, you'll also see that actually they're very low in terms of recruitment numbers. Okay, so then also treatment as usual. What are we comparing to? It's really, really tough. We're putting a lot of energy into understanding what happens in usual care, but the alternatives like an attentional placebo control, they're harmful, we know that, and also active controls, what do we do in those? So these are really challenging questions for us, non-pharmacological interventions around our control conditions. And also sometimes groups don't want to take part in these studies where they're going to have to wait for things as well. Okay, and then obviously in creative health, we have a landscape where, I think there's a recognition that there are benefits, public health benefits, but as we saw in our commissioning video, these are often short-term funded projects. They're small groups, they're tailored to specific contexts and communities, which is absolutely brilliant. That you have these creative arts groups with different interests tailored to very specific communities in contexts. So replicability is difficult. Limited choice of sensitive outcomes and inadequate outcomes. And then, what do? You try to collect some pre and post. It's very difficult to get follow-up, and then limited evaluation and research skills. And so that's why people often ask me to come along and give some advice about that. Okay, so in conclusion, my key point is who is the audience, as this will determine what and how success is measured. So, what is your audience asking you? And I suppose, are they asking the right questions? Are we asking the right questions around this work within a health context? And very much, I think that a lot of the methods and approaches that we're trying to fit into a medical context come from that pharmacological methodology, which is seen as robust and which is higher up the rankings in terms of evidence-based practice. So we've had a go at that, but we've learned some things that are tricky, and you know, we need some more ideas about how to think about that. Okay, so I will leave it there, and I think I'm